Welcome back to the Curbsiders. I'm Dr. Matthew Watto, here with my great friend, Dr. Paul Nelson Williams. In this short video, we're going to be talking about renovascular hypertension, which, Paul, I don't know that I had a great grasp of what exactly this was before we talked with Dr. Luther about this on a recent episode. How about you?
Yeah, same. It felt very much like a board question, but like now I actually feel like I have a much more concrete understanding of it and probably much more directly applicable to a lot of my patients than I previously recognized, probably.
Yeah, because like where this would come up is I think just a lot of textbooks maybe gave me this impression that everyone with resistant hypertension, we should just shotgun the workup, which should include some sort of imaging for bilateral or just renal artery stenosis in general. It doesn't have to be bilateral. And one of the main take home points from this discussion with Dr. Luther is that you should not go looking for it in every patient because most of these patients are not going to benefit from a revascularization and you're just going to treat them medically. But Paul, how would we recognize patients who you might think about doing that workup, um, who might have a more advanced case?
Yeah, I think we talked about on the episode one of the example cases that we gave is someone whose blood pressure just kind of fell off a cliff. Someone who had been hypertensive, had been reasonably well treated on an ACE or an ARB and maybe a calcium channel blocker, maybe not perfectly controlled, and then all of a sudden they kind of go into flash pulmonary edema. And maybe this happens a couple of times, or we even talk about sort of just an acute hypertensive crisis that manifests as hypertensive encephalopathy, which is not common, but can happen. And so these patients where these acute changes that had been reasonably well managed on the right medications maybe should sort of prompt you to think about renal artery stenosis. And in most cases, probably the atherosclerotic renal artery stenosis, not the fibromuscular dysplasia that we can talk about in a little bit.
Right. Yeah, those being probably the two big buckets that you should think of, at least from our perspective, would be person with risk factors for cardiovascular disease, atherosclerosis, or somebody without those risk factors who might have fibromuscular dysplasia. And then, Paul, what about this? He mentioned a couple times this. Let's call it the blood pressure and creatinine spiral. What's that about?
That yeah, it's a terrifying phenomenon where I will be reaching out to my friendly neighborhood nephrologist quickly, where sort of every time that you escalate their antihypertensive management, their creatinine then goes up, and so you're sort of chasing the hypertension, and the creatinine worsens, and you're like, I can't stop the antihypertensive because the blood pressure keeps climbing up, and then you find yourself just sort of panicking. That might be a tip if this is someone who has bilateral renal artery stenosis, and again, we're probably from atherosclerotic disease specifically, and we did talk about some very specific instances where you might actually send one of those patients to surgery if that's possibly helpful. So that might be one of the few instances where you would actually do something procedurally to maybe try to fix that if you're just sort of stuck because everything seems to be going the wrong direction, even though you're doing all the right things.
Right. So the other type, this fibromuscular dysplasia, I think most of us think of that as young women, but he mentioned no, it could happen at any age, but classically it is a younger patient, younger woman. Think of this in a young woman who has like early onset hypertension, especially if it's like accelerated or malignant or resistant. And it could also be if you see somebody who has like a single small, they could, let's say you have imaging on that person, they have a single small kidney without any other known neuropathy. Or if you're hearing arterial bruits on exam, and they could be anywhere. He said he listens brachial arteries, carotids, everywhere, abdominal bruits. So listen all over. Those patients, they could have fibromuscular dysplasia, and that is often treated with angioplasty, not even stenting, Paul, which I thought was cool, and that can actually have a good outcome. When we talked about the treatment for patients, let's say you think you have someone with that blood pressure creatinine spiral and you think maybe this is bilateral renal artery stenosis. It's been hard to prove that those patients benefit from revascularization, especially if they tried to go after mild cases. So I think you're definitely going to be working with specialists if you're referring anyone there. But that is Paul, let's talk about the imaging. Let's say we think we have a case, we want to know what imaging to get. How do we go about that?
I feel better about this after the episode, though still don't feel great. But talking to Dr. Luther, I mean, I think my typical approach previously to talking to him would be to start with ultrasonography because it's non invasive and you're not worrying about contrast lows and all that kind of stuff. But he's been fooled by ultrasonography before, and even disease can progress relatively quickly, and you can sort of have interval changes that might be missed with duplex ultrasonography. Um, Dr. Luther likes CT angiography. He thinks that you sort of get better definition with that, and then there is a role for MR angiography, but if these patients have advanced kidney disease, then it's off the table because you do need contrast for that. And of course, it would make most people, I think, a little bit nervous. And there are, I think, a certain subset of patients where you can sort of pass go and send them right for actual angiography as opposed to just sort of imaging. And I think that there's a specific list.
I think it was like if you think you have a classic case of fibromuscular dysplasia, so like you have this young woman, accelerated hypertension, or and maybe you know that one kidney's smaller than the other, or if you hear an arterial bruit when you're listening on exam, then you think you have a slam dunk case of fibromuscular dysplasia, or if they have fibromuscular dysplasia elsewhere known, then that would be more of a slam dunk case, and those patients might go right to angiography because he said it can be difficult to make that diagnosis of FMD sometimes on the other imaging modalities. And I think the last point I'll make is if someone's had prior imaging, don't be afraid to look at that and evaluate the kidney size um, based on prior imaging, just to see if that gives you any clues. Um, but he mentioned most of the time kidney size discrepancy is not because of renal artery stenosis; could just be congenital or some prior insult to the kidney in the person's life. Again, this is a topic probably not very familiar to most internists, but something that I think comes up a lot because I bet you a lot of people are ordering this renal artery ultrasound, not really knowing whether or not it's a good idea and what to do if they found it. So this episode could really help you with that. And hopefully this short video gave you at least a couple tips there. And with that, this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole. Paul?
And folks, we love knowledge food, don't we?
Until next time, I've been Dr. Matthew Frank Watto.
And as always, our main Dr. Paul Nelson Williams, thank you and goodbye.